Can you hear me?
You sound great. Thank you.
Sound check for Tito.
Can you hear me?
Good.
All right, good. So what we're going to do is show some injections around the ankle. And we had a request from Josh to do the subtalar joint. We're actually going to start with that, subtalar joint. And then we'll do the lateral ankle tendons, and then we'll do the anterior joint, and then we'll do some other things as we go along. But starting then with the subtalar joint. This is a somewhat tricky joint to inject. What I first do is find the bony acoustic landmark. So I'm scanning from the lateral aspect of the ankle, and that's the calcaneus being shown there. And then I come up a little bit higher. What I'm looking for is I'm looking for the joint between the talus and the calcaneus, the subtalar joint, and that's that right there. Okay, so now that is my target. That's that gap between those two bony acoustic landmarks between the calcaneus and the talus. This thing's falling off. Yeah, there we go. You can all see. Great. Okay, so see those two bony acoustic landmarks. That's the subtalar joint. That's lateral aspect. So then what I usually do is come from above to below. So I'm going to go along the face of the probe from above, okay? And then I'm going to sort of angle so that, down into that general angle, and then find myself by just, jiggling. Okay. So, okay, let me hold this. A little bit back. Okay, sure.
You guys can see the angle now?
Okay. Okay. And then what I'm going to do here is I'm going to adjust, to jiggle, and then adjust. So I'm going to gradually come here a little bit more anteriorly and down. So my needle now is there. And actually, I'm pretty deep toward the joint right there. I'm actually a little bit posterior to maybe ideally where I'd like to see the needle. So I'm going to come back in a little bit anteriorly as I adjust. And when I do that, again, there's my needle, and there I am in the subtalar joint. And now I'm going to go ahead and inject it. You can see the joint stand up. Okay? So basically, now, this is just one way to approach it. I mean, you can come from any angle you'd like, but the problem is that if you come from posteriorly, you may have to deal with the Achilles or the scrotal nerve. If you come from inferiorly, you may be fighting the malleoli a little bit. So I tend to like to come, once I see that angle, to come from above to below and then aim for the subtalar joint. The key thing is finding your bony landmark. That's actually the joint. Okay, now Tito, do you want to take the peroneal tendency? Sure.
All right, so our fibula is our friend here. You can see there, the tendon. The bone is right, I can't really point to it from around that. There's the bone, there's the back of the fibula. You can see the brevis is the small tendon right above the bone, and then the long is on top of it. And at this level, we have a common tendon sheath, so we can inject at this level. You can go kind of anywhere you want. I usually come from posterior because of the fibula, and most people are pretty slender. What you can do is you can put a pretty big gel pad there if you want. And that'll help you identify where you want to go. That might be good.
Yeah, come on this side.
Good thing we have smarter people than me when it comes to being able to see things. So you can see I'm coming from this side. I'm actually, there's my needle tip there. I'll show it to you a little better. And you can see I'm underneath here. I got underneath the tendon, so I like to get underneath them so if I need to traverse. And you can see I'm just going to put a little bit of fluid in here. You can go between them if you're not getting enough. You don't want to go in them. And then you just keep giving fluid if you're going to do tendon sheath injection here. So I actually went in between them here to see if I can just send that up a little bit better. There we go, just so you can see the distension of the tendon sheath. If you see fluid somewhere, you can see as I come down, you can see the distension of that tendon sheath there. You can see all the way down. And you can see my needles kind of in between the two right there. Usually I just penetrate the sheath. I don't have to usually go between, but he's got a lot of rigor mortis, so I'm just trying to get it so you guys can see. But there you can see it'll distend. Make sure to distend both tendon sheaths there, so you see nice fluid around there. We typically will go up where the common tendon sheath is. You can come a little lower, but then you have to do them separately, so it's better to be a little bit higher when you're doing these. And I think it's a lot easier to do it in short axis than long axis. In short axis, I feel like it's easier to adhere to the tendon sheath. If you go long axis, you can skive off a little bit. So it makes it a little bit more of a difficult injection in my experience. And you don't really have anything using your way, but you obviously want to put color Doppler on to make sure you don't inject or go through one of those little vessels there, because you can't get any hematoma. Okay, as we turn, slide them out here.
Linear, bigger linear, probably not. Yeah, that's the idea.
Okay, so now we'll go to the Tibial injection. And again, I'm going to be coming in for this time.
You want this or would you want the other?
This one we use. Yeah, this one we use really.
Yeah. I'm going to make my best attempt at holding this leg. There's like gel and fluid surrounding this leg on the table, so I'm going to do my best to hold it well for.
All right, doctor. Actually, I see it fine like this. Thank you. All right, so bottom, actually, though, we'll be able to show the anatomy better with the
it might give you a bigger sense.
Yeah. Let's switch to the other probe so we can get a better look at the anatomy. Okay, good. So basically, now you're going to find a number of ways that people suggest to do ankle injections. I'm going to show you the way that I used for a long time, and I like it. And so, I like this approach. But we just have to optimize the image a little bit. We don't need all that stuff, for one thing.
And then we need some better contact here.
There's air in the probe cover. So we'll switch back to the other probe. Okay, so back to the smaller linear. Sorry about that.
We didn't get the Trojans like the person in the audience to suggest.
Yeah.
One had better.
Less
air.
Okay, so basically, the first thing, of course, always is to get oriented to your bony landmark. So we have the distal tibia, and then we're going to come down, and there's the talus. And this patient actually does have a teardrop of fluid. We did not put it there. There is a little teardrop of fluid within the ankle joint. So what I then do from that position, I know some people come in this position and they go short axis approach right down into that fluid. But I like to see the entire course of the needle to one great extent because the dorsalis pedis lives near there. And I'd like to make sure that I, do not go where I don't want to go. So this is how I do it. I identify the anterior tibial tendon, and then I identify the cartilage at the dome of the talus. Okay? So if I go a little more proximal, that's tibia, but that's talus there. And if I come even a little slightly more between the two, there's that fluid that we saw on the long axis. But in general, a lot of the ankles that I inject have zero fluid. So I'll just show you how to do it. So I put the anterior tibial on this side of the screen, and again, I'm looking and I'm seeing, okay, if I come down about 1 centimeter from the anterior tibial and then shoot across, that's going to get me into the plane that I want to be in. I've come about 1 centimeter deep from the anterior tibial and shot across. And now I just aim towards the cartilage, and see, I'm right on top of the cartilage now. Okay? Now if I turn into the long axis plane, you can see I'm at the cartilage right there, right on top of the hyaline cartilage now as I come more laterally. There I am, right on the hyaline cartilage. So I am, by definition, in the joint. So I'm on top of the hyaline cartilage. Then from there, I can go ahead and give my injectate, and you can see the joint extend up. Okay? That I find to be quickest, safest, and also easiest because I'm able to see the needle very perpendicularly there and not have to worry about angle. And I can still confirm by looking at two views. So that is my go-to way to inject the ankle pretty much every time I have to do it. Very nicely. Okay, so now moving on.
Not so fast, Lev. Lev, can you show injecting the ankle through the ATFL?
A lot of people do that, yeah.
Yeah.
Let me turn this lateral.
So while we're turning this in the air a little bit, most of the injections that I do for the ATFL are for patients who have had prior ATFL injuries and now have impingement. So they get this scar tissue buildup right at that gutter there. And so when we dorsiflex, I'm trying to dorsiflex here, not getting dorsiflex. But the bottom line is that tissue gets caught in between the fibula, which is there, and the talus, which is there, and really builds up. And so we've found very good success, in fact, about to this publication, on coming in and penetrating with scar tissue at the anterolateral gutter. Also injecting some steroids because we want to shrink that tissue in order to get it to not impinge so much. So I tend to come towards proximal with my needle. So identify those bony acoustic landmarks. And we get some more gel, so again, we have very little soft tissue to work with here. And I'm going to float my probe a little bit so that I can get a better image. Okay, so there's the area of the ligament. And now I'm going to enter. Can you see me? Where you camera first, people? I'm going to come this way. So generally I'll come proximal, so proximal in this case is on the right side of the screen. Now I'm going to enter along the right on top of the fibula there, and then angle down into the area of the ligament. Now if I'm just going to be injecting, the top around the ligament systematically, I'll go where I am now. So I'm actually going to penetrate the ligament because of impingement, then I'm going to go into it like this and then repeatedly puncture it. And again, we're about to submit a paper to Foot and Ankle International on this procedure for treating chronic ankle impingement.
And could also do it in short axis.
And you can also do it in short axis. Yes, you can. You can. I just whatever works for you. That's just what I've always done. Okay. Next, should we do the plantar fascia? And yeah, it's going to be hard to get a position properly. And
your skill on getting positioning.
Okay, so for the plantar fascia, so we're used to identifying for diagnostic purposes the plantar fascia and the long axis, and this we're looking at it for the first time now. This patient actually has the ultrasound signs of plantar fasciopathy there with a fixed fascia calcification right there, hypoechoic, another calcification there. So this is an abnormal plantar fascia. Now, if I'm going to be penetrating the fascia or doing like a PRP or something, I'll come from behind into that plane, like this, and come along the fascia from posterior to anterior. Okay, so there's my needle, and I'm going to come into the fascia and pierce it, and then do my fascia needling and/or PRP injection. So I'm just going to do a simple injection, and I'm sorry, I didn't hear the whole lecture, so I'm not sure exactly how Kentucky to do it, but I usually do mine in the short axis, and then I come medial to lateral, because usually most of the pathology is on the medial side of the foot. Okay? So there I have the fascia in short axis where it's most abnormal. Again, I want to be parallel to the probe so I get the best picture. So I look at the screen and think that's 1 centimeter down. So I go 1 centimeter down from my probe, and then I shoot it a needle across. Okay, and then I find myself, and there I am. And then I slowly advance into the fascia. Now, I am definitely in the camp that thinks that the worst possible complication that you could have from this injection is fat atrophy. And I know that it doesn't happen that often, but I have seen it happen in patients who are injected without imaging. So I do tend to want to place this injection in the fascia. I'm going to inject the fascia camp, so I'm going to use steroids. But of course, nowadays, with a lot of needling and PRP and not steroids. But but I do steroid in something that really increases pain. It does give them relief for a few months. That's how I approach that.
You ever think about using non-particulate steroid like Dexon instead of analog to prevent the atrophy, or no?
That's a good question, whether you use something to try to prevent the atrophy. The problem is that I do want some atopic effect in the fascia.
Exactly.
So I'd rather use
That's why most of us like analog.
Yeah.
I'm just curious if someone asked me that question. So it's good to use analog, but one thing to know about that. I like that atrophy, but
yeah, I want the fascia to atrophy somewhat, because that I think helps. All right. Oh, from this position too, the retrocalcaneal bursa. This is another one where I want to make use of physics here, because we have the distal Achilles coming down, and then here it is coming down to the calcaneus. Now, when I say make use of physics, so I want to be able to make sure that my probe is perpendicular to my needle. So I'll place that's going to be the bursa approximately where that hypoechoic area is, right there. And then, let me just get this at a good level. And then what I'll do is, similar to when I inject the ankle itself, I look at the screen and I say, okay, about 0.5 centimeter down is where I need to come. And then I'll come about 0.5 centimeter down, shoot straight across, there I am, and then go deep to the Achilles tendon and get right into the bursa there. Now this bursa doesn't have any fluid in it now, but I'll fill it. There it is filling, okay? So that's how I approach the retrocalcaneal bursal injection. Again, sort of making sure that I'm parallel to the probe and parallel to the floor with both my probe and my needle. That's how I get into it. Okay, what is it? Okay, postgeotibial. You want that one?
Sure.
Okay.
I mean, it's the same as the Peroneal. It's kind of the same approach.
Okay.
I don't know if there's something that audience wants to see.
Yeah, what is the
We've
audience
already
want?
sort of done all the time.
There are a lot of things we can show. Audience requests?
Tibial nerve block.
Tibial nerve block, please.
Tibial nerve block, okay.
It's blocked already. Next question.
You can't feel a thing. So if I keep him like this, I can probably do it this way. Change for a block.
Oh, yeah.
I'm going to try to do it this way. All right. Let me see. We're sort of working with the positioning of this. See if we can. I feel like I need a shower at this point. A lot of gel and goop. All right. So what we usually do is we'll find the malleolus, which you can see is this acoustic landmark right there. You slide a little bit more sort of posterior and central. You can see 2 tendons are there.
Move your left hand. Thank you.
So there you can see there's 2 tendons. So Tom, Dick, and very nervous areas that we talk about. So Tom being the posterior tibialis, Dick, the flexor digitorum right there, and then the neurovascular bundle right there. And so you can either do it at this level. If you want, you can come more proximal if you don't want to worry about the muscles or the nerves. You can do it right here. So you can do it anywhere you want. You want to go before it branches, obviously, because if you do it after it branches, you won't get a good block. Have a long. I'm going to try to come from the contralateral side, but usually you want to be on the same side, obviously. So we're sort of breaking our typical rules here. And then we come in, and I'll usually go deep first, get into the sheath, and then descend up that sheath until I get good distension. I'm going to come in there. And so coming from the opposite side, you can also then kind of go on top if you want by angling your needle a little bit up. But you can see it already circumscribes the nerve. There's the nerve. You can see you want to be in the sheath for these. At least when I do PRPs, I do these. I'm sure that's what they said during the lecture. And you can see there, you want to see that nice halo around there. Once you get that nice halo, I usually typically only put in like 2 or 3 cc's. That's all it really takes. And then you'll see that the fluid will kind of be around that nerve. Make sure it travels up and down a little bit. And then we wait a minute or two, and then I just get an 18-gauge needle and touch the heel to confirm that this is a good nerve block. Usually it is before we do anything on the plantar fascia when we're going to do fenestrations and things. It works out really well. It's helped out with our waiting room because before people were screaming so much, most people were leaving before we did any more injections. Because it can be very painful if you're going to do PRP and fenestrate those the plantar fascia. So it's an easy injection to do, and if you look at this area here, if you're doing it, your drape can actually cover it, but you don't have to put 2 drapes. You just have a single drape where you can get to the nerve, and you can do the plantar fascia without having to sort of undrape or redrape, or you can keep everything nice and sterile. So it's actually a pretty slick maneuver for those of you who want to do fenestration, PRP, or whatnot to the plantar fascia.
Any other requests?
FHL tendon?
FHL tendon injection.
FHL tendon. It's pretty much the same as all the other tendons. Again, we're going to come short access. I may need, now that I've sort of given so much fluid there, hopefully we can see a little bit better. So the FHL, as we all know, goes underneath the subtalar. So if everyone can see that big kind of, there you go. That's the bone, the subtalar.
Move your left hand.
Right there. I'm going to move my hand here so you can see. And then you can follow it. Now if we're going to do an injection, usually what I do is I just find where there's fluid. But one way of finding is there. You come up a little higher up, you can see that posterior to the, you can see there's it runs through a little groove there, right? So on the posterior tibia there, you can see those nice effects. You can actually see it quite well there. So a lot of times we'll inject in that area because it's another landmark in terms of bony landmarks where you know that that's it. So obviously you got to be careful for the nerve above. So you have to come underneath it. Usually I'll slide down a little more distally, find it there, or you can go even further distally depending on where the pathology is. So this is the same as what we just showed in terms of anatomical, like getting some short access, but you can go anywhere you want. It's the same as when we did the peroneal. You just have to know how to find it. That's really the key. And I think usually if you just find that groove, or if you come down distally and find the subtalar, they're easy anatomic landmarks for you. Okay.
Anything else before we wrap it up?
Okay, great.
Okay, thank you guys.
All right, that's our last.
Any questions before I